Thank you for coming to this session. My name is Albert Varon. I'm professor of anesthesiology and vice chair for faculty development in the Department of Anesthesiology at the University of Miami Miller School of Medicine, and I'm also the chief of anesthesiology at the Radiotrauma Center. The presentation today is Challenges and Controversies in Trauma Anesthesia. So the overall learning objectives of this session is to identify current challenges and controversies in trauma and burn management, evaluate the literature on trauma and burn resuscitation, and also to assess how new trends in trauma and burn management impact anesthesia care. Injuries take the lives of about 4.4 million people around the world each year, in which 80% constitutes about 88% of all deaths, according to the World Health Organization. In the United States, trauma is the third leading cause of death in all people, and this is following cardiac disease and cancer, and is the leading cause of death in the individuals younger than 45. In addition, trauma is the leading cause of years of potential life lost. In this panel presentation, we're going to review some recent challenges and controversies in trauma and burn management. This include the use of regional anesthesia in trauma patients, pediatric burn resuscitation, and damage control resuscitation. To address these topics, what we have done, we have put together an expert panel of anesthesiologists from several level 1 trauma centers across the country. This is the place where I work, which is the Radiotrauma Center in Miami, Florida. And it is one of few freestanding hospitals dedicated exclusively to the care of trauma patients. For the past 26 years, the Radiotrauma Center has also served as the United States Army Trauma Training Center. My colleague, Dr. Daniel Perez, also works at the University of Miami and Ryder. He's an assistant professor and attending trauma anesthesiologist at Ryder and is fellowship trained in regional anesthesia. Dr. Meera Gangadharan, she's an associate professor in the Department of Anesthesiology at the McGovern Medical School and a pediatric anesthesiologist at the Children's Memorial Hermann Hospital in Houston, Texas. In addition, Dr. Gangadharan is the Vice President of the Trauma Anesthesiology Society. Finally, Dr. Justin Richards, he's an Associate Professor in the Department of Anesthesiology at the University of Maryland School of Medicine and an attending anesthesiologist and critical care medicine specialist at the R. Adams Cowley Shock Trauma Center in Baltimore, Maryland. So what we're going to do is we're going to have Dr. Perez is going to talk about regional anesthesia in the trauma patient. Can it mask compartment syndrome? Following him, we are going to have Dr. Meera Gangadharan is going to address pediatric burn resuscitation. Is it the same as in adults? And finally, Dr. Richards is going to address hypotensive resuscitation. Is it really a component of damage control resuscitation? Please write down your questions, or you can use the My App application that you have for the meeting to put your questions, because we're going to try to have some time at the end of the presentations to address some of your questions. So we're going to start with Dr. Perez, who's going to address the first topic.
Thank you, Dr. Varon, for that introduction. Good morning, everybody. I'm Dan Perez. I'm from the Ryder Trauma Center at the University of Miami. And I'm going to talk today about regional anesthesia in the trauma patient. All right, so my objectives for this talk, I'm going to give a brief overview of acute compartment syndrome, or ACS, in the trauma patient. We're going to try to understand the concerns that we have with regional anesthesia in these patients, specifically in extremity trauma. I'll be give a brief review of the current evidence, and then I'll try to leave you guys at the end of the talk with some practical considerations for its use in clinical practice. So acute compartment syndrome is a surgical emergency. We tend to worry about it most in tibial and forearm fractures because those fracture patterns tend to be the most susceptible to acute compartment syndrome. This occurs when the pressure within the compartment, that tends to be tight, bounded by two bones and then a tight osteofascial compartment, rises to the point where perfusion is impaired. The hallmarks of this syndrome tend to be pain out of proportion to the injury or to the stimulus, and pain with passive stretch, specifically in those muscle compartments that we're worried about with increased pressures. We also need to worry about paresthesias, pallor, paralysis, and pulsiosis, although these are relatively late findings and tend to be the herald symptoms of ischemic limbs. Trauma in and of itself complicates the evaluation of these patients. Our patients tend to be obtunded, they can be intoxicated, they can be receiving lots of other opioid medications or other pain medications, low GCS, so they may or may not be able to alert us to the impending acute compartment syndrome. So in terms of incidence of ACS, it's relatively difficult to ascertain. There's no key, discrete diagnostic criteria. We tend to look at the presence or performance of fasciotomies afterwards to find that out. It's been estimated that the incidence of ACS has been 7.3 per 100,000 males and 0.7 per every 100,000 females. So it is much more common in our male population. Other demographic risk factors that will sort of set you off for ACS tend to be, like I said, age less than 35, male sex, high component of muscle mass, high energy trauma with very complex fracture patterns, vascular injuries with subsequent reperfusion. That edema from the reperfusion injury can set you off for acute compartment syndrome afterwards. Crush injuries, large soft tissue injuries, prolonged tourniquet use, and bleeding diatheses. So how do we diagnose ACS? Like I said before, it's a clinical diagnosis, and we really rely on the presence of pain. And that sort of is the crux of this talk. Pain out of proportion to injury, pain with passive stretch, and the 5 Ps that I discussed previously that are hallmarks of ischemic limbs are things that we look out for, but those are late findings. So once you get to that point, you're sort of beyond the beyond veil there. So if there's any sort of, especially in our trauma patients where they may or not be able to alert us to the pain, or we've blocked them, we need to consider compartment pressure measurement. This can help you confirm the diagnosis. So what you're going to try to do is measure the compartment pressures and subtract that from the diastolic blood pressure. And if that pressure difference is less than 30 millimeters of mercury, you should consider fasciotomy. So why do we care so much about ACS and missed ACS? If we miss ACS, we can leave our patients with significant morbidity and mortality. Not only can we leave them with a lifetime of pain, chronic pain that tends to be intractable, they can develop contractures, rhabdomyolysis, renal failure, nerve injury, infection, and can even result in death. So this is the dilemma. We need to try to balance our patients' comfort with maintaining vigilance for acute compartment syndrome. Pain is the key early symptom and warning sign of ACS, at least historically. And we do know that regional anesthesia, its main goal is to reduce pain. So our fear is that if we reduce the pain, we lead to delayed diagnosis, delayed fasciotomy, all the way to permanent disability and death. So the origins of this conflict between ourselves and our orthopedic surgical colleagues goes back decades. We've got a multitude of case reports that have described delayed diagnosis, and most of that blame, when regional anesthesia techniques have been used, have been placed on regional anesthesia techniques. Rightfully so, our orthopedic colleagues have become cautious because of medical legal concerns, and they've taken to mostly opposing the use of regional anesthesia in high-risk fracture cases. Here's a review of some case reports that we have. On the left side there, we have a case report of a 20-something-year-old male with a femur fracture that underwent a triple nerve block, so a femoral obturator and a lateral femoral cutaneous nerve block, to treat the pain from the femoral injury. The patient also had a tibial spine injury as well. That patient had no pain postoperatively, but then developed the inability to extend his great toe. Compartment pressures were checked, they were measured, he was found to have compartment syndrome, underwent fasciotomies, and was left using an ankle-foot orthotic. So that's one of the herald cases that we talk about. Another one in the lower right-hand corner, we talk about a 70-year-old male that underwent a fixation of the distal radius fracture under an axillary block, but that patient developed blistering and swelling at the site of surgery 24 hours later without pain, presented to the hospital, was found to have compartment syndrome of that extremity. The other two cases are slightly more complex. They're patients with bilateral femur fractures that had epidurals placed for postoperative analgesia. These were done with very dense blocks. Patients had nearly complete sensory blocks and complete motor blocks of bilateral lower extremities. They developed lower extremity compartment syndrome, underwent fasciotomies, and had permanent disability. So essentially, these case reports are showing the herald cases of patients that have received nerve block and then ended up with long-term morbidity. So a brief overview of the current evidence. There are no randomized clinical control trials proving risk or lack thereof with the use of regional anesthesia. There have been a few recent systematic reviews and case series that have shown that ACS can still be diagnosed in the presence of regional blocks. But we need to remember that ACS can occur even without pain, and there have been several case reports demonstrating that as well, particularly in the pediatric literature. What we need to remember is that breakthrough pain can facilitate diagnosis. So if we have a block in place or we're treating our patients with pain meds, and then we're escalating doses or redoing our nerve blocks or bolusing catheters, those are the patients that are at risk for acute compartment syndrome. So the key determinant in whether or not we can diagnose it is being aware of it and being vigilant. So for the next part of the talk, I'm going to go overview some of our systematic reviews and case series. So this systematic review looked at 6 individual case reports. 2 demonstrated a delayed diagnosis of ACS after a nerve block, while the last 4 showed timely diagnosis despite it. This sort of brings into question whether or not ACS can be diagnosed in the place of a nerve block. So while there's a nerve block in place, if these patients are requiring escalating doses of medications or boluses of catheters or redo nerve blocks, those patients need to be evaluated for tight compartments, need to have their compartment pressures checked, and possibly go to the OR for fasciotomy. Here we have a large retrospective chart review of patients with long bone fractures over about a 10-year period. About 26,000 patients were included in this review. 20% of them required surgery, and 91% of those patients requiring surgery received regional anesthesia. They calculated the incidence of ACS, and they found it to be 0.1%. So it demonstrated a low incidence of acute compartment syndrome, despite the routine use of peripheral nerve blocks. This was done in a strictly protocolized fashion, and the patients were monitored by a multidisciplinary care team. So that's sort of, I think, what we need to take away from this is strict monitoring, good protocols, and the like. This last research report from June of this year looked at the relationship between perioperative regional anesthesia and the risk of missing acute compartment syndrome. It was a single center at the University of Florida, level 1 trauma center. And they looked at the 3-month presence of disability after surgery. They defined missed ACS as a motor deficit still present at 3 months. These patients were either randomized to get these patients either received a single shot nerve block or received a peripheral nerve catheter for postoperative pain. And they found that the incidence between the patients that had regional anesthesia and those that did not was more or less equivalent. So they didn't show a difference, but the University of Florida uses strictly protocolized block techniques and strictly protocolized follow-up patterns, which is most important there. Okay, so what we need to keep in mind is breakthrough pain. So pain from acute compartment syndrome often breaks through the analgesia provided by a block. This can happen in patients that are requiring increasing doses of block medications, increasing rates on their catheters, and increasing doses of opioids. Because it's severe, it escalates quickly, is disproportionate to what we would expect. We need to be aware of the risk for acute compartment syndrome, and this needs to be a major warning sign for us as clinicians. What do ASRA and ESRA say about this? These are recommendations from the pediatric literature, but I do think it's reasonable to extrapolate it to adults. They recommend single injections with low concentration local anesthetics. If you're going to use a continuous peripheral nerve block, do it at low rates with low concentrations of medications. They want us to exercise caution with using adjuvants that can prolong or densen our blocks so that we don't miss acute compartment syndrome. These patients should be monitored strictly by an acute pain service or by a combined orthopedic and acute pain service. And if acute compartment syndrome is suspected, urgent compartment pressure monitors should be done. So potential recommendations for my talk, things that I like to apply to my own current practice. Avoid dense, long-lasting blocks in high-risk trauma patients. If you are going to consider doing a nerve block in a high-risk fracture pattern, use a dilute concentration of local anesthetic or a short-acting local anesthetic to try to bridge the patient to better pain control. Consider catheter use whenever possible. Our peripheral nerve catheters are a double-edged sword. They can give long-lasting pain relief, but if you stop it, you can reassess for acute compartment syndrome in short order. Clearly document a baseline neurological status so that you can compare the baseline to the current status so that if there's a change, you can be alerted to the presence of compartment syndrome. Frequent neurovascular checks, and have a low threshold for compartment pressure testing. So key takeaways as I wrap up my talk. Pain is important, but it's not the only sign. It is the sign that we need to be most aware of because it tends to be the earliest. Regional anesthesia in these patients requires vigilance, not wholesale avoidance. Safety with these techniques comes from good communication with our colleagues, good communication with our patients, good communication with our nursing, and good protocols. Patient safety and comfort should always be our focus. So to wrap up our talk, when I said, can regional anesthesia mask acute compartment syndrome? The answer is yes, but it doesn't necessarily have to. Thank you.
Good morning. Good morning. I want to thank Dr. Varan and the organizers for having me. And I will talk about pediatric burn resuscitation. Is it the same as in adults? I have no conflicts of interest to disclose. I would like to convey my special thanks to Dr. Alexis McQuitty, who's the chief of anesthesia at Shriners in Texas and has been incredibly helpful in guiding me in preparing this talk. So before we talk about what is different between a pediatric and adult burn resuscitation, let's talk about what is the same. So both are trauma patients. And that is, it's very important to remember that because the burn injury can be very distracting and can distract the provider from more critically life-threatening injuries. So it's important to follow ATLS guidelines when assessing and resuscitating these patients. Volume resuscitation is critical in both groups. Airway management is very important and sometimes challenging. In inhalational injuries, mucolytics, inhaled mucolytics like heparin and N-acetylcysteine are used in both groups, and there's evidence that the earlier they are used, the more beneficial they are. Hypothermia is a risk in both types of patients. It's important to remove all jewelry, anything that can become a tourniquet as the body becomes edematous after the burn injury. Watches, necklaces, and very importantly, contact lenses have to be removed. Diapers should be removed because if there's hot water or anything that is hot in the diaper, that will continue to injure the patient. Lines and tubes should be long because when the body swells, these will get dislodged. Secure the lines and tubes appropriately. And in both groups, the patient's palm size, the adducted finger palm size is roughly 1% of total body surface area. For some background, burns continue to be among the top 10 causes of unintentional morbidity and mortality in children. But outcomes have considerably improved. So in the 1950s, if a child had a 50% burn, they had a 50% risk of mortality. Whereas today, a child with 90% burns faces that same risk. So outcomes have significantly improved. In young children, the commonest cause of burns is scald injury, whereas in older children, flame burns tend to be more common. Scalds are usually more superficial and flame burns are usually more deep. Children, because of their thin skin, can get very easily burned with hot water. So the bathtub can be a very dangerous place for small children. Just 10 seconds at 130 degrees Fahrenheit can cause a third-degree burn in an infant. It's also important to remember that scald burns can mimic inhalational injuries. Although there's less sloughing of the tracheal mucosa and less cast formation, they can still have some edema and some sloughing in the trachea, and they may require intubation even in the absence of apparent and obvious inhalational injury. Social media has been a problem for this patient population. Older children tend to take a lot of risks. And in social media, there are any number of challenges. They have, how long can you place your extremity on ice? How long can you tolerate it for? There are other challenges where they ask the person to douse themselves in rubbing alcohol, light themselves on fire, and see how long they can last before they have to jump into a swimming pool to save themselves. So children do these type of things. We had a family of 3 in our burn unit for a long time because 3 siblings decided to do this at the same time. Estimation of the burn wound size. Children, their head is a larger percentage of their body, and their lower extremities are a smaller percentage of their body compared to adults. So in children, it's about 19% in the head, and adults are about 10. The lower extremities, 15 in children and 18 in adults. And only partial and full thickness burn should be included when calculating the total body surface area burned. When these patients first are met, you can start fluid rates arbitrarily at 125 for children less than 5, 250 for children between 6 to 12, and 500 for children above 13. And then once the actual area burned has been calculated accurately, then you can titrate it down to 3 ml per kilo per percent body surface area burned for 24 hours and calculate the rate that way. Smaller children do need dextrose in their fluids in order to prevent hypoglycemia. So if they're less than 30 kilos or less than 12 years of age, they need dextrose. Usually D5 at maintenance will suffice. Goals to titrate the fluids to. Urine output goal in children is 1 ml per kilo, whereas in adults it's usually 0.5 ml per kilo. And some other parameters to follow include warm extremities, good peripheral pulses, a comfortable, arousable child. Systolic blood pressure targets in infants is about 60 to 70, and in older children it is 70 to 90 plus twice their age. So if you have a 6-year-old, it'll be 82 to 102 would be their systolic blood pressure target. And why is this important? Because in a burn, there are 3 zones of injury: the central zone of necrosis, and then surrounded by a zone of stasis, and then hyperemia. So in the zone of stasis is a salvageable area of skin. The zone of necrosis is already gone. There's nothing we can do about it. So if there is under or over resuscitation, that zone of stasis can be lost and become the zone of coagulation. And that is shown on the right, a lower figure, whereas the figure on the left is one of a patient who has been appropriately and timely resuscitated, and the zone of stasis has been preserved. And this is just a real child showing the zone of necrosis, zone of stasis, and zone of hyperemia. Over-resuscitation has its own problems, and in children it is easy to over-resuscitate them because the body surface area is often over-calculated, and they sometimes tend to be hypotensive. So if you are giving a lot of volume to these children and you feel you're not getting the physiological response that you expect, do not hesitate to use point-of-care ultrasound and take a look at the heart. If the heart is not contracting properly, because myocardial dysfunction does occur in children with burns, that patient group will need a low-dose inotrope. And more fluids are not going to help that patient. So low-dose inotropes do have a role in pediatric burn patients who have myocardial dysfunction, who are unresponsive to fluids. And these are pictures of patients who have been over-resuscitated and have developed compartment syndrome of the extremities and the abdomen and required escharotomies, fasciotomies, and laparotomies. Temperature management is more challenging in children because they have 3 times the body surface area of adults. And so keeping them warm, they lose a lot of heat through their heads. So plastic bags or foil caps can be very helpful, and warming the room to more than 90 degrees can be helpful. The airway can be particularly challenging. And just to recall the formula for small children, it is age, divided by 4 plus 3.5 for cuffed tubes. And cuffed tubes are indicated in all age groups. If you can get a cuffed tube into the child, place a cuffed tube, no matter how small they are. In very, very small infants, you can use 3.5 size cuffed tubes. And after the age of 2, the formula that I just quoted will apply. So the other indications for intubation include sedated children, GCS less than 8, 40% total body surface area burns, full thickness facial burns. And before instrumenting the airway, if you can do a nasopharyngoscopy and a quick bronchoscopy can be very helpful. Children will tolerate a nasopharyngoscopy, and it'll give you an idea of whether there's already injury and if that airway is going to swell or how much time you have. Securing the tube is also challenging, and you can use these silk tapes. I want to draw your attention to this child on the right. A red rubber catheter has been passed through the nose, brought out through the mouth, and then tied in front of the face between the nose and the lips. And then the endotracheal tube has been secured to that red rubber catheter loop. That way, there's no tape on the face, and it is a very secure way of keeping endotracheal tube as well as nasogastric and nasoduodenal tubes, which we know are critical to this population because nutrition is so important. And in this patient, what has been done is they have put an umbilical tape has been passed through the nasal septum, actually. So 2 red rubber catheters are passed through each nares, brought out through the mouth, and then the umbilical tape is tied to the tips of the red rubber catheters in the front that have come out through the mouth. Then you bring it out through the nose, so you get a loop across the nasal septum. And then you secure the endotracheal tube and nasogastric tubes to that rubber tube, and you don't have any tape on the burned area of skin. This is a child with severe contractures, and the patient had come in for reconstructive surgery. And these patients, you really need the surgeon by your bedside before you start sedating them. And oftentimes that area, we will all clean it out, make it sterile, even infiltrate some local anesthetic, so that if the surgeon has to do an emergency scar release, the area is prepped and ready to go. Children are often very, very anxious. Even if the pain is controlled, they continue to be anxious. So treating pain anxiety from the get-go is critical. Every tool in the box you can use, child life, keep the family close to the child, virtual reality, all beautiful medications. Precedex is a wonderful medication in this regard. Ketamine, propofol, midazolam. Methadone is increasingly being used to reduce overall opioid doses, and it has been helpful. In children, we should always consider non-accidental trauma, especially small children. So if there's delay in seeking care, if the child is less than 4 years old, if the history does not match with what is being seen clinically, if there are bilateral lower extremity injuries, it's very high risk for non-accidental trauma. And if you see patterned burns, like the shape of a pressing iron or a cigarette butt or a curling iron, those are all signs of child abuse. As far as transfer criteria go, all full thickness burns to the face, hands, feet, genitalia, peritoneum, more than 10% partial thickness burns. If the facility does not have the resources to take care of children, and any inhalational, electrical, and chemical burns should be treated at a dedicated burn center. This is just a comparison, a head-to-head, an 8-month-old and a 30-year-old with the same percentage burns and what would be the different resuscitation parameters. So the rate of fluid, the type of fluid, dextrose, urine output targets, intubation indications, the need to refer to a burn center, and the need to think about non-accidental trauma. And this slide summarizes pretty much the same thing. And that's all I have. Thank you so much.
Well, good morning, and excuse me. Thank you, Albert, for organizing this panel, and I thank you all for being here, especially a little bit early on a Sunday morning. Going to talk a little bit in this last part about hypotensive resuscitation, and specifically its role in damage control resuscitation. And so to provide a little bit of a review on really what is damage control resuscitation and what does that mean in 2025, this was a concept that really got popular, I'll say in the late 1990s, but especially early 2000s. We learned a lot about damage control resuscitation from military conflicts in the Middle East. And what we were starting to see was from damage control surgery described in the early 1990s, these long kind of definitive operations that were being done very early, hours of operations, exposure to cold, hypothermic temperatures, a lot of crystalloid, very few blood products, was leading to poor outcomes. So damage control surgery was trying to minimize a lot of the operative exposure. Then we evolved to damage control resuscitation, which really became getting earlier blood products to patients, minimizing iatrogenic complications, but getting early packed red blood cells and then early plasma. And that's what we've learned from a resuscitation standpoint of earlier plasma in these bleeding trauma patients. And one of the earlier descriptions of damage control resuscitation really described it as a treatment strategy that targets the conditions that exacerbate hemorrhage. And this in 2010, differing from our current resuscitation approaches, which were really early crystalloid and then packed red blood cells and then waiting for plasma based on laboratory coagulation tests such as INR or PTT. And the goal of damage control resuscitation was more aggressive control and correction of that coagulopathy and the metabolic derangements. Again, a lot of those being iatrogenic, but also many of these also occurring at the point of injury, realizing that many patients, 10, 25%, were arriving to a trauma center coagulopathic. And so what this figure really demonstrates is when we think about trauma and hemorrhage, and as Albert said, trauma and hemorrhage being one of the leading causes of death, especially in younger patients. But the most common cause of preventable death in trauma is non-compressible truncal torso hemorrhage, something that you're not going to be able to gain control of with a tourniquet. And so what was happening in these patients, especially back in the late 1990s, early 2000s, is even if they were getting packed red blood cells, they were still getting a lot of crystalloid. We were doing longer operations on them, leading to further tissue hypoperfusion, more acidemia, hypothermia, coagulopathy, which then led to further bleeding, further coagulopathy, further bleeding, and it was just a vicious cycle. And that's how we got this term, almost the triad of death, which now has kind of evolved into a death diamond where we add hypocalcemia to the acidemia, hypothermia, and coagulopathy. So damage control resuscitation was aimed at trying to minimize this triad or now diamond of death. And one of the tenets of damage control resuscitation when it was initially described, and still is talked about a lot, especially in the trauma literature in North America and among many trauma surgeons, is this idea of hypotensive resuscitation. Many of us are probably very familiar with hypotensive resuscitation, even outside of trauma, whether it's in joint replacements, such as hip replacements, where we're trying to minimize blood pressure for a period of time to minimize bleeding. That's been shown fairly well to work, certainly among the orthopedic surgeons. Maybe even spine operations, if you've done spines, where the spine surgeon is saying, hey, there's a lot of bleeding, anesthesia, can you reduce the blood pressure? That's going to make all this better. Or even in vascular operations. A lot of our experience and I'll say the ideas of hypotensive resuscitation came from open abdominal aortic operations, which some of us may remember when we were doing those pretty frequently, but at least historically, we're doing much less of those because of endovascular capabilities. And a lot of our experience and familiarity with open abdominal operations is becoming less. But hypotensive resuscitation, especially when it comes to trauma, has a lot of its origins with vascular surgery. And this is because of one vascular surgeon's experience describing his cases in an editorial in a paper published back in 1991. And one of the descriptions that this vascular surgeon gave, and his statement was, I feel that no significant attempt should be made for blood volume resuscitation until the time of an operation, and that systolic blood pressure should be kept around 50 to 70 millimeters of mercury, and that only small volumes of whole blood or crystalloid should be administered until at least there's hemorrhage control with clamping of the aorta. And I emphasize here whole blood. This was 1991, and we're talking about preoperative whole blood resuscitation. It's not a new concept. But furthermore, he goes on to describe that in his patients, the systolic blood pressure was stable, and I tell our trainees I'm not sure what stable means, but I'll interpret that to mean unchanging, or certainly without variation. The blood pressure was at least 90 millimeters of mercury or higher in a majority of his patients. Their survival rate was greater than 90%. which leads me to ask, where's the hypotension? This was minimizing crystalloid using blood products, allowing the patient to do physiologically what they were wanting to do. But this is where we get hypotensive resuscitation, at least in trauma. So with this idea, then we get more clinical studies. And I'll show you at least some of the animal data, which invigorated a lot of enthusiasm for, yeah, hypotensive resuscitation works. This was a hemorrhage model in pigs, where these pigs were bled to a point of hemorrhage. They were resuscitated with crystalloid. Now, lymphocytes resuscitated with a clear fluid, without packed red blood cells, without proteins, without platelets. Crystalloid. And they were resuscitated to a mean arterial pressure of 40, a map of 60, or a map of 80. And what this figure shows is in those patients who were resuscitated with crystalloid, to that higher mean arterial pressure, they had lower survival and were dying earlier. Those patients, or excuse me, those pigs resuscitated with crystalloid to a map of 60 actually had the best survival, especially out to about an hour. Even in our own anesthesiology literature, similar concepts have been published about 15 years ago. This now in a rat model of hemorrhage. Rats resuscitated with crystalloid to a map of 40, 50, 60, 70, 80, or 100, and survival was significantly lower in those rats resuscitated with crystalloid to a map of 100. This kind of seems to make sense. It's almost super physiologic. But even the maps of 70, 80, the survival was significantly lower compared to those rats resuscitated with crystalloid to a map of 50. And the conclusion in this study was we should be resuscitating patients who are bleeding to a lower mean arterial pressure. This is our data on hypotensive resuscitation, at least in terms of animals. Well, what do we know about it in humans? What's our clinical data? In 2018, a meta-analysis in the Journal of Trauma, just by reading the conclusion in the abstract, would state that permissive hypotension, hypotensive resuscitation, allowing and tolerating a lower blood pressure, may offer a survival benefit over conventional resuscitation in patients with hemorrhagic injury. You go on to read the last part of the conclusion. It states, however, a majority of these studies were underpowered. So let's look at some of these studies in humans to show really what they were describing. And the largest study that contributes the most patients to this meta-analysis was a prospective randomized study done in 1994 in Houston in patients with penetrating torso trauma, so gunshots, stab wounds to the chest. And really what their intervention was limited to no pre-hospital crystalloid or their standard resuscitation, which was crystalloid. So this was a no crystalloid versus crystalloid resuscitation. What they found is those patients who had no pre-hospital crystalloid, they had a lower mortality. It was statistically significant. When these patients arrived at the hospital, those patients who had less crystalloid had a statistically significant lower blood pressure, 72 millimeters of mercury, compared to the larger crystalloid resuscitation, which was 79. While that's statistically significant, I would say that's really not clinically significant. And the purpose of their intervention was not to target blood pressure, it was to give less crystalloid. So this study is what contributes most to our meta-analysis saying hypotensive resuscitation is good, when in fact they weren't targeting a blood pressure. This was limiting crystalloid. A few more prospective randomized studies. One by Rick Dutton in 2002. This was actually done in Baltimore as a single center study, but trying to minimize and tolerate a lower blood pressure during bleeding. And their goal systolic blood pressure in their intervention group was 70. In actuality, these patients had a systolic blood pressure of about 100. Even though they wanted the blood pressure to be 70, the patient said, no, we're going to give you 100. No difference in outcomes. Mortality was really low. Another prospective randomized study, this was a pre-hospital intervention, multi-center study by the Resuscitation Outcomes Consortium, looking at pre-hospital resuscitation with crystalloid, targeting a lower blood pressure. In their intervention group, they wanted a systolic blood pressure of 70. Patients said, nope, we're going to give you a systolic blood pressure of 100. No difference in outcomes, no difference in mortality. Another single center study done in Houston looking at intraoperative hypotensive resuscitation. They wanted an intraoperative mean arterial pressure of 50 or greater. In actuality, in those intervention patients, the MAP was above 65. What was alarming is in that study, in the discussion, they said, no, we couldn't achieve hypotensive resuscitation, and it's theoretically possible that the anesthesiology team did not perform the intervention as needed. that was their reason for saying we couldn't achieve hypotensive resuscitation. We've never achieved hypotensive resuscitation in humans. And we didn't have the outcomes we wanted. It was anesthesiology's fault. We've got to stand up as a specialty, having the expertise that we do, to say, here's how we need to resuscitate these patients. So no, we haven't been able to achieve hypotensive resuscitation, at least clinically, in humans. So another, at least, myth going along with hypotensive resuscitation. No, we can't achieve it. Even when we want to achieve it, the patients are going to do something different, and we're not seeing a difference in outcomes. Yes, we can give less crystalloid. But this idea that hypotensive resuscitation prevents the quote-unquote popping of the clot. And I have a little bit of an objection to that, because yes, we know that when you give animals in a controlled hemorrhage situation a lot of crystalloid and you raise their blood pressure to a higher threshold, yet they're going to bleed more. But we haven't actually documented this in humans. And the reality is, what contributes to coagulopathy in a weak clot? That's hypotension, acidemia, hypoperfusion. If you have a problem with a clot, fix the clot. Coagulopathy is something very different than just managing hemorrhage. And I want to take a moment at least to say, if you have questions about coagulopathy, ask Ken Tanaka up here, he's in the front. But he's the one who's taught me everything I know about coagulopathy, but really how different managing coagulopathy is than managing hemorrhage. And these are two totally separate problems. But I say fixing the clot is fixing the clot, and that is not allowing further hypotension and hypoperfusion. So should hypotensive resuscitation be a part of damage control resuscitation? No. We can't achieve hypotensive resuscitation. We can give less crystalloid, but the patient's going to do what the patient's going to want to do. Furthermore, if you need at least more evidence of where we are with damage control resuscitation, look no further than what they're doing here in San Antonio, where they have a very robust pre-hospital system, where they're able to give pre-hospital whole blood. And what they've demonstrated is these patients who are getting whole blood are indeed sicker. But in fact, when they're getting this early pre-hospital whole blood, they're arriving to the trauma center with an improved shock index, which is simply heart rate over systolic blood pressure. And if you have a low shock index, that means your heart rate's lower, your systolic blood pressure is higher. These patients who are getting whole blood are giving less crystalloid. That's part of damage control resuscitation. And they're having fewer massive transfusion events. We're actually reducing the amount of overall volume that these patients are getting. And another study just showing what early blood products are doing and how I think this is changing our understanding of resuscitation and some of the physiology is in New Orleans, where they're also giving pre-hospital whole blood. This was a study in penetrating trauma. There's a very big difference in mechanism between penetrating and blunt trauma. But these were predominantly, actually all penetrating trauma patients who they received pre-hospital packed red blood cells. These patients were getting blood, early blood, a whole lot more quickly, 7 minutes compared to longer than 20 minutes if they were waiting to get it at the hospital. And ultimately, what they saw was those patients who were getting early packed red blood cells had a higher systolic blood pressure, a lower heart rate, better shock index, lower shock index, and their mortality was significantly lower. So by giving early blood products, these patients have got a higher blood pressure and they're living. This is not hypotensive resuscitation. In fact, it's the complete opposite of what we thought about hypotensive resuscitation back 30, 35 years ago. Also, what this is doing is we're giving patients less crystalloid. So ultimately, what's the right blood pressure? And the short answer is we don't know. It's probably going to be patient-specific. The ideal blood pressure for a 70-year-old who fell or has been in a car crash is going to be very different than your 21-year-old who has a gunshot wound to the abdomen or a gunshot wound to the chest. But at least according to some, I'll say, big organization recommendations, and one of those being the Trauma Hemostasis and Oxygenation Research Network, which is an international collaboration of civilian, military experts, trauma surgeons, anesthetists, blood bankers, and at least their comments, based on the best available literature, which admittedly very retrospective, but they state at least trying to keep a systolic blood pressure of around 100, and it should never fall below 90. And I think that's really important to think about, especially with blunt trauma. You know, blunt trauma is the most common mechanism of injury. Many of those patients will have a head injury. Hypotension does not do patients with a brain injury any benefit. But if you can keep that systolic blood pressure between 100 to 110, at least until hemorrhage is controlled. But the important part is the early blood products. So I'll reemphasize, should hypotensive resuscitation be a part of damage control resuscitation? And the answer is no. Really, damage control resuscitation is when patients bleed, get them what they need, which is either early whole blood or a plasma-based resuscitation. It's not hypotension, and it's certainly not crystalloid. So thank you very much. Look forward to any discussion.
Well, we're right on time, and the idea is to leave the last 15 minutes of this session so we can have an interactive discussion of the topics that we presented. So we're open for Q&A. I'm going to start with the ones that are already on the app, and you can do that, or you can, in a few minutes you can also stand and tell us your questions. And this is a fun part of the session. So, but before we start, I'm just curious, in this group, anybody works in a burn center? Can you raise your hands? Okay, very good. Just to let you know, so if you are an anesthesiologist that works in a burn center, you must document CMEs on burns. So just write this one down. There's not many, but it's difficult to find those CMEs. And it will be, your coordinator is going to ask you for documentation, so make sure you keep track of this. Okay, so first question, this one will go for Dr. Perez. Dan, is the use of near-infrared spectroscopy to detect compartment syndrome? And also they want to know the benefit of single shot versus risk.
So near-infrared spectroscopy has been used, although direct compartment pressure monitoring is the gold standard in terms of confirmatory testing. It's still a clinical diagnosis, so despite what those monitors are going to tell you, if you have the indication, if you have the inclination that there's compartment syndrome going on, they need to go for fasciotomy. And then what was the other question?
Yeah, there's another one. What concentration of local anesthetic do you use in your blocks in patients at risk of acute compartment syndrome?
So I generally use for my analgesic blocks, which is what I'm doing mostly in these patients. I'm not usually doing a surgical block for these. I'll use a dilute concentration of about 0.1% ropivacaine. We avoid bupivacaine in these patients at our institution. So I will purposely underdose the block just to get some analgesic benefit, but not necessarily to completely eliminate the pain. So I want to make the patient more comfortable, but I still want to keep that threshold for pain to worsen.
And what is the position of the Trauma Ortho Society on the use of blocks in masking compartment syndrome?
So they take the opposite view that we do. They generally want us to avoid it, but they're basing their evidence on the case reports that I mentioned previously and expert opinion. They have different concerns than we do because they're the ones that have to manage these complications, and these are their patients. So I think it's just going to take a further discussion between us and them to arrive at a better consensus.
So how do you convince your ortho colleagues? What is your technique to convince them that even if it's a tibia, we can still block the patient?
Usually it's going to require a lot of persistence and showing them the literature. If anybody can figure this out and let me know, that'll be way more helpful for all of us. But I think it's just going to take some time and more data.
At University of Florida, Gainesville, they block all of them. So we can use them as an example to do that.
Whatever they've done, we need to follow because despite us showing our colleagues and we have a similar patient population, they still don't want us to.
Go ahead.
So you said the acute pain service follows these patients, right? I'm sure that adds to, helping the orthopedic surgeons get their buy-in.
It does. As long as you have a robust pain service that's able to manage these patients, like we have a large volume of them, so it's really a strain on the system. But treating their pain and following up their pain, measuring their post-operative opioids can sort of clue you in that something else is going on.
Very good. So, Justin, if you can address this question, it says, when the blood pressure is low, do you speed up the blood transfusion or you go up on pressors?
Separate those into two parts. Speeding up the blood transfusion part, I think that's actually a really interesting question because a lot of times we're either using a rapid infusion system or pressure bags or just even squeezing the bags to try and get it in faster. The reality, and this is my opinion, but partly coming from, again, this DORD network where these international folks, military, have had a lot of experience with this, of just rapidly giving boluses of fluid. We know in septic shock doesn't make a benefit. and probably is not benefiting us in trauma. One, when you just give a big bolus to the heart, it's going to overdistend the right ventricle, put a lot of pressure on the right ventricle, and that's why most of these patients are dying. You're also damaging their blood vessels, and that's part of the endotheliopathy that goes on in trauma. So I'm very much actually against any type of pressure bags or the rapid infusion systems. I think if you give the blood, the patient's going to do what the patient's going to want to do. As far as vasopressors, that's a whole other topic. And to succinctly say it, I'll say if I'm going to use a vasopressor, it's vasopressin as a straight infusion at the start of hemorrhage. There's actually some data in trauma patients to show vasopressin can be beneficial, but it's vasopressin as an infusion, and that's what I'll say about vasopressors.
Okay, I just want to say the message should be fill up the tank first before you start using vasopressors. Make sure the patient is not hypovolemic. But I agree, there's some data that the use of, one point when you know that the bleeding is under control and you're having vasoplegia, that vasopressin may be the way to go. We're currently part of a national multi-center trial comparing vasopressin versus placebo. So it's an RCT that we're starting. We're one of the institutions, and we're going to be looking at the outcome of those patients.
I think in the next 5 years or so, we'll certainly know a lot more about whole blood, but then also the contributions of whole blood, tranexamic acid, calcium, and vasopressin.
Yeah. So stand by. Hopefully by the next meeting. Then we try to do this panel once a year, and we bring those topics. Hopefully we'll have the answer for next year at the trauma panel. Okay, Mira, are there pediatric burn resuscitation decision support tools for pediatric burn patients, like Burn Navigator?
We don't use any of those. I'll have to look into it and get back to you because we don't use any decision support tool in our institution.
Except the Braslow. Okay, Dr. Richards, platelets in the store whole blood do not seem to aggregate well. Is the whole blood really more effective than 111?
Not quite sure what the whole blood is doing, other than maybe something good. What we've seen, and this is the same, I'll liken it to plasma. There's something good in plasma, and obviously then whole blood has plasma. I think the biggest benefits of whole blood are going to be with penetrating trauma. At least that's what we've seen in the literature. I think we're seeing that at our place, and it's when you're using more whole blood. A unit of whole blood and the rest component therapy probably doesn't matter. I think when you have a high ratio whole blood, yes, that's going to be superior to component therapy. And the reality is you're giving less volume and you have less crystalloid. In each unit of red cells, packed red cells, plasma, platelets, there's some anticoagulant preservative. You add all that together, that's almost 500 cc's of crystalloid right there with 3 units of blood product. So I think that's one of the detriments to component therapy.
And Mira, this one is for you. What is the role of albumin and plasma in pediatric burns management?
So there are some formula that include albumin in the resuscitation regimen. So it's introduced after about 12 hours. So after the initial capillary leak phenomenon has started to subside a little bit. There are some studies that have shown that even introducing albumin at about 8 hours can be beneficial and reduces the overall crystalloid needed for the patient. But if you do see that you're giving a lot of crystalloid, like in excess of about 6 ml per kilo per body surface area burned, then it's a good idea to start introducing albumin, about half ml per kilo of, 25% albumin. You can introduce albumin once the crystalloid amount is exceeding, is going beyond what you would expect.
Justin, do you use albumin in trauma?
No.
Yeah, at the trauma center, I hid it. They can't find it. So it makes it easier. By the time they get it, the case is over.
I've had that question before of, okay, if you don't have blood products and crystalloid is bad, what about giving albumin as a colloid? Yeah, I see the rationale of it, but it does not have the proteins that plasma has. And I come back to what do we know is most beneficial in trauma? Early plasma. So I would put colloid, albumin in the same category as crystalloid. Just don't even think about it in trauma.
Well, the only quality that doesn't leak out is blood, correct? So that's one that you want to use. in that case. And by the way, so most of the trials in trauma in general have not shown any benefit of albumin. The only difference in all those trials really is cost. On the other hand, in the cases of head trauma, we do not know, but the mortality increases with the use of albumin. So it's not only that it doesn't help, it's, you get a worse outcome in patients that receive albumin. So we, again, don't use it, but we do use it in burn patients, that you said. The timing, it's important. What is the role of tranexamic acid in trauma resuscitation? I'll be happy to answer that one. So TXA, there's a very nice review paper recently, a meta-analysis. It has a place in trauma resuscitation in any patient who shows up we suspect bleeding or hypotensive. And we have found that not only in those patients, and actually, if you look at the papers on trauma in general, we don't have really class 1 data on anything. We do it because we think it's the best thing. The only thing in our armamentarium that has class 1 data is TXA. That means when you have a randomized controlled trial of 20,000 patients, 10,000 placebo, 10,000 TXA, that's the mother of all RCTs, correct? So, and not only that, the reason people were not using it initially was very simple. It's too cheap. Nobody was pushing it. Okay, TXA, think about TXA, CVS, you can get it for $101, TXA. It was over the counter in the UK for the treatment of menorrhagia. So no drug was pushing that. At that time, people were pushing 7A. The price of a dose of 7A was $10,000. 2 doses of that can buy you a minivan, $20,000. And it didn't pan out. The use of 7A is dead in the trauma setting. We don't use that anymore. But TXA, it's there. And also we have found in the CRASH 3 study that also is of benefit in head trauma patients as well. So we are using it. There's a question about the dosing of TXA. The CRASH 1 study showed 1 gram given as a bolus and then 1 gram over 8 hours. And many of the trauma centers, and I can ask here, we have a lot of people here, we have gone out to the 2 gram dose, because it's just more feasible to give it practical than starting an infusion. And some of the head trauma studies have shown that it's beneficial, so we're using 2 grams. No more than that, because then seizures could be a problem. So yeah, there is a role for TXA in trauma resuscitation. We should know that earlier is the better. Should be given within an hour, even up to 3 hours, but ideally within an hour. We don't know why, but after 3 hours, mortality increases. So it's early use of tranexamic acid. And that's the answer to that. Now let's see how we're doing. Any other questions from the audience? Please, go ahead.
Steve Frank from Johns Hopkins. Anyone can answer this question, and it's about giving whole blood to young women of childbearing age, because the trauma surgeons have gone gung-ho for whole blood, saying that it saves lives, but the randomized trial isn't even done yet. And they're saying we should give it to young women, despite the fact it's all O positive, and they could be alloimmunized and have future pregnancy problems. So are you guys giving O positive whole blood to young women in Miami or at shock trauma?
Yeah, in Baltimore, literally a couple miles away. And this was with our blood bank. The blood bank said we are comfortable giving O positive whole blood to women of childbearing age. And you're right, the randomized studies on whole blood aren't even out. And there's a lot of push from trauma surgeons. Yes, this is saving lives. I think when we get the randomized studies, we're going to find out the differences aren't as big as we've heard they are when we look at all our trauma patients, but I think there's specific groups of patients who are going to benefit. And at least in our population in Baltimore, that's where I come back to the penetrating trauma, I think is where we're going to see the biggest benefit. Another San Antonio study, this was addressing the transfusing young women with O positive blood, but showing it would have taken 200 years to have one woman in the San Antonio region alloimmunize if they had received whole blood. And this is another kind of component of the Thor network, but they also are emphasizing giving whole blood to women of childbearing age, because the ALO immunization and the high drops can be treated once it's recognized. That's the important part of being able to recognize it and have the follow-up, which is hard enough in a trauma population.
That's what ROGAM is for.
Yeah, we do this.
And we do give whole blood in women as well. Yes, sir.
Matt Palasko, Washington Hospital Center. Radial art line in the first hour of a trauma, friend or foe? I find often people are getting over-resuscitated because once they get that radial art line, they stop checking a non-invasive blood pressure cuff, and there's usually a discrepancy of about 30 points on a map because the initial vasoconstriction is dampening your arterial waveform, and it's a missed window of you're probably over-resuscitating in that first hour. Do you find that? I often have to like tell trainees to like check a cuff just once, just a little bit, because once they get that arterial line, they just keep going up on pressors. They keep giving more and more volume, and they've often missed a window where they could have de-escalated. I find. I don't know if you've seen that as well, and that's like the radial art line is my least important priority in the initial
I'll pick up
resuscitation.
that one.
Yeah.
It is clear that when you're starting trauma resuscitation, you should first focus into blood replacement. So doing that takes precedence over sticking an A line. Now, if you have a lot of people, that's
Sure.
different. But if you don't, sometimes people are looking for their line and they have no IV access. Yeah. So IV access goes first.
Right.
But arterial lines should be placed early because it really can guide you in the management. Non-invasive blood pressure is not as reliable as an arterial line. And remember, you're not only going to be measuring blood pressure, you're going to be getting blood gases, electrolytes. You can do all of that, which you can't do with the non-invasive cuff.
Sure.
So we do jump straight into, if you have enough people, we start simultaneously. If we don't, then venous access comes first, and then arterial line goes second. And it's and yes, we do use the blood pressure cuff, but we slow it down. We put it every 30 minutes once we have the A line, so it doesn't include the A line. But the measurement is, in all the data shows that it's much more reliable, and the mean pressure should be about the same. That's the way you know if you're A line. And
That's what I'm saying. I think you miss the window where you're not. You're over resuscitating because you stop checking your cuff. You're getting your less proximal pressure when you're using just a radial arterial line.
what do you think about that, Justin? I'll bring it up.
Your kind of first question, friend or foe, I love an arterial line as early as possible.
But a radial arterial line, that's the point. Like if you had a FEM, that's different. But
And that's where it's an interesting question. And I think I wouldn't pin this on just our radial or femoral arterial line, but add in another monitoring equipment, because I don't know if that's going to tell us so much about the over-resuscitation, but the other monitor I would throw in is TEE. Now, there are a lot of difficulties, I don't want to say limitations, but difficulties potentially using that. But I think that in combination with an arterial line, for the reasons that Albert was saying from a metabolic standpoint, but then also visualizing the heart, I think can help immensely with the resuscitation. To your point of, we often over-resuscitate patients. That's where we are now, is we don't know when to stop.
There's another session coming. We'll be happy to stand for a few more minutes if you have any other questions. I want to thank the presenters, and I want to thank you for attending this session. And we'll see you next year at the trauma panel.